So good afternoon, good evening, everybody. I'm Ignatius Bell. I'm a policy consultant for the National Council for Asian Pacific Islander Physicians. We want to welcome you to this month's Conversations with NCAPIP, where we highlight the work of Asian American, Native Hawaiian, and Pacific Islander physicians working in and on behalf of our very diverse communities. And we're continuing this month's conversation with a focus on COVID, still front and center, unfortunately, in all our lives and globally. And we've got a great panel to share some of their perspectives and experiences working on COVID, and particularly with a focus on vaccines, which is obviously the most topical issue for us right now. So I want to welcome our panelists. I will introduce them briefly and then ask them to share in this conversation over the next 40 minutes or so. So our first panelist is Dr. Raynald Samoa from the City of Hope. He's an endocrinologist, has been a board member for NCAPIP, and has been working with the Pacific Islander COVID response team in really lifting up the perspectives and voices and the needs of Pacific Islanders and Native Hawaiians. We also have Dr. Pia Pannaraj, who is at USC, University of Southern California, and Children's Hospital Los Angeles. She is both a pediatrician and also works on infectious diseases and brings a lot of knowledge around vaccinations even before COVID and certainly now with COVID. And then finally, we have Sudhakar Nuti, who is an internal medicine physician at Massachusetts General Hospital and has also been in policy advisory roles for North Carolina and New York, and brings some really great perspectives of the work that he's been doing in those places. So let me start with Dr. Samoa. And as we usually do with these conversations, tell us a little bit about how you became a physician, why you became a physician, and how you ended up working where you are now at the City of Hope before we get into the COVID conversation.
So real quick, I was naturally drawn to the sciences. I actually didn't go into college thinking I was going into medicine, but I just naturally gravitated towards the life sciences. And then I started doing some community work. I was exposed to sort of medicine as a career in that way. And then I just naturally did better in my endocrine classes. And so that the career kind of picked me. I found myself needing to study less and just doing better. And I think, that was the affinity. And then when I was in sort of early residency, the reports started to come in about the higher rates of diabetes and, actually then the obesity rates and chronic disease as a whole. And that kind of shoved me out of the silo of academic medicine into sort of more advocacy. When you're doing that work already, when crisis happens, people tend to go to those already existing structures. And so hence the response team, that the Pacific Islander COVID-19 response team came about because of that. We were already doing chronic disease work. And the community, we already were engaged in community, and a lot of the group that we brought in had high trust equity. So that in a nutshell is how I came to be where I'm at.
Great, and we'll come back and talk more about the response team. So Dr. Pannaraj, how did you become a physician and then end up in pediatrics and infectious diseases?
Yeah, hi everybody. I think that I knew that I wanted to be a doctor since I was young, as one of those people. But I really wanted to focus on working in developing countries, low and middle income countries. So I was actually an economics major in college. focused on developing countries, and just and then became a physician. I didn't really know that there was such specialty as infectious diseases until probably my third or fourth year of med school. I knew I really liked the detective work part of it, and so infectious disease was just sort of a natural calling for me, I think. So I love my job. I now focus a lot on vaccines and preventative health, and actually have do a lot of research in global health, trying to understand, why certain vaccines don't work as well in some of the low and middle income countries, and working with other countries in terms of policy and trying to increase vaccination rates, those kinds of things. So I've been lucky to be able to tie everything together.
Great. And Dr. Nuti, how did you decide to become a physician, and then the somewhat unusual pathway very early on in your career of doing this policy advising to state and local governments?
Yeah, my name's Sudhakar. I'm an internal medicine primary care resident at MGH here in Boston. I also wanted to be a doctor since I was a kid. I was an immigrant, grew up pretty poor, Section 8 housing, food stamps, but I had a really good pediatrician growing up. His name was Dr. Falk. And I was like, I want to be like him growing up. And so that was sort of like my North Star. And then along the way, I realized you could be a doctor and do other things to help people. And so initially I did basic science research, which a lot of people do early on. And then I'm like, I'm not really helping the people I want to help in that way. And I started doing public health research, and then sort of drawn towards government later on in med school, where I realized, sort of aligned with my value system of trying to do as much good as I can for the people who need it most, and try to do that at scale in a somewhat timely way. And so I sort of found myself working a bit in North Carolina at their health department pre-COVID, and then during COVID, and the same with the New York City Health Department. And now I'm here now finishing my medicine training to be a primary care doctor.
Great. So it's great to have all of you. So let me go back to Dr. Samoa and talk more about how, when COVID began in the United States, immediately as we started to look at data stratified by race and ethnicity, first the data wasn't there and missing for a lot of Asian groups and Native Hawaiian and Pacific Islander groups. But once the data did start becoming apparent and released, we saw the immediate disparities among Pacific Islanders and Native Hawaiians in so many states, in so many contexts. So talk about what that experience was like, and then the fact that you had this chronic disease network working on issues of obesity and diabetes, and how you were able to sort of pivot to then take up some of the work on COVID.
Yeah, it was so the Sacramento Bee actually dropped the rates in, I think, mid-April. And I was actually just recovering from COVID. I think California went on lockdown mid-March, and I literally caught COVID 2 days after the lockdown. And so as I was coming out of it, that's when the reports started to surface. And I was like, of course we have it. I had it. And so I reached out to other counties, some of our other networks, and because LA County, no, I think it was the California Department of Public Health that reported those rates first. So I reached out to King County in Washington, Multnomah County in Oregon, Utah, Arkansas, and lo and behold, King County was reporting the same thing. They were saying their rates were the highest in the state in any ethnic and racial group. We didn't have a lot of data in Hawaii. There was a lot of anecdotal reports in Arkansas, but no numbers. There wasn't any data in Multnomah County that was disaggregated by race and ethnicity. And we didn't have county data in California, So we had some rumblings, but there was all these like missing pieces of information. And so, I reached out to the groups that we commonly work with in those states. and we formed a response team, and there was public health experts, community-based organizations, anybody that wanted to join was given a free invitation. And the first thing we realized that we had to do was we needed data. We needed disaggregated data. So, I sat on way too many county public health department meetings, explaining to them the reason why we need it, because all these other counties with significant Pacific Islander populations were showing their significantly high rates. And to the credit of those community-based organizations and their advocacy and their relationships with their county health departments, immediately after that, Multnomah County reported their disaggregated data in Oregon. And in Oregon, NHPIs had the highest rate of confirmed cases. LA County reported their data and was able to show that they had the highest rates there. Arkansas reported their data a week after that and showed that they had the highest rates. In Utah, they were able to break down their data literally the day after they met with the group. And they had the second highest rate, but over the past year, they now have the highest rate of not just confirmed cases, but mortality. And Hawaii, their rates weren't as high. And so we knew that something was brewing. The most troubling thing about Hawaii was we were telling them, because Hawaii had a little bit of an advantage on the rest of the country in that they were able to shut borders a little bit more effectively. But what we told Hawaii was, if this holds true, if this trend holds true, then you have a population that is at risk, that is at high risk of contracting COVID. And we got ignored for quite a while. And then when they started opening up their travel again, lo and behold, the Native Hawaiian, well, mostly Pacific Islanders that were living on the island, comprised of Polynesians and Micronesians, they had the highest, significantly highest rates, and they continue to do so, and their mortality rate just skyrocketed. So what was really sort of troubling about that was we predicted it. We told them, we gave them about a 3 to 4 month head start, and nothing happened. And so, this is the sort of arrogance of public health and medicine, in that there's a lot of dismissal sometimes of community-based organizations and the way they're able to sort of relay data and information. For the most part, we are seeing a better response. Hawaii has responded, a little bit better than when they initially did, and the rates are starting to level off. But just like our Asian brothers and sisters, Native Hawaiian and Pacific Islanders are not a monolith, and we can talk about this later, but there is stark differences in regards to geographical location. Like there are huge differences in vaccine hesitancy based on the state you live in. And the social determinants of health that are basically what drives this. We now have data on that as well. And that was, firmly collected and driven by community efforts. So sorry to be long-winded.
No, thank you so much for detailing that. And again, it's, a history that probably is not very well known. And as much as, our public health authorities say they are data-driven and science-driven, when that data and science is presented to them, they're not necessarily responding to it or as you said, even interested initially in actually collecting the data. So let me go to Dr. Pannaraj. Even before COVID, as you mentioned, you had a research interest and you were looking at vaccines and vaccine hesitancy, even just with other immunizations and vaccines. So talk a little bit about, as now everybody's talking about hesitancy, what you had known beforehand, and then how you've applied that now to the COVID experience, particularly given the diversity of our Asian American, Native Hawaiian, and Pacific Islanders communities.
Sure. Yeah, we've been working, trying to figure out vaccine hesitancy for quite some time, and there are always cultural differences in, you know, the reasons for hesitancy. With routine, and then the other thing is that routine vaccinations or hesitancy against routine vaccinations is different than, say, hesitancy for flu vaccine. And I would say that COVID vaccine is going to be similar to flu vaccine. And there's a couple of issues. One that's brand new, you know, right now it's brand new, so there's the issues with that. And then in the years to come, it's going to likely end up being similar to flu vaccine, where we get an annual shot. So there'll be different reasons for hesitancy when that comes around. So, you know, for COVID vaccine, we have seen it looks, when you just glance at the numbers, the aggregate numbers, it looks like, oh, Asian Americans, no problem, we're all getting vaccinated. But that's not true, doesn't really give the whole picture. So when Asian Americans are, you know, there's a high percentage that are involved in healthcare, first responders, and those that were on the front lines in terms of getting vaccinated at the very beginning. So our numbers at the beginning really shot up maybe before others. But, you know, when you look deeper into the data, it really varies by geography and household income, who's getting vaccinated and who isn't. So highly educated Asian Americans, that they're doing okay. But when you look at more new immigrants that are coming, for example, to the United States, who have their own business, they tend to be lower in numbers. And then some states, so in California here, we have very high percentage vaccinated, but in other states like Pennsylvania, when I last looked, the numbers were around, or under 10% for Asian Americans, so very low. You know, so I think that there is definitely a lot of room for us to delve deeper into what some of that hesitancy the reasons for hesitancy. A lot of it has to do with mistrust of the healthcare system, some with language barriers, especially for immigrants, both distrust and language barrier, and they tend to go together. If you have a language barrier, then there's even more, you know, mistrust. So I think that there's still a lot of room to delve deeper, to get more data. We don't have the data broken down, you know, by, we just have overall race ethnicity, but not as much by each of the different Asian ethnicities, and also by income level and location, things like that. We just don't have that data to that, the depth that we needed.
Great, and folks have already raised, you know, the state that they live in, so geography, but also income level, education level, immigration status, language, those are all, I think, important factors. So Dr. Nuti, you've recently published a great commentary in JAMA that talks about really this concept of lay epidemiology, of what really matters to people, not what those of us at that national or federal level, what comes from the CDC or comes from federal government officials. It's how people understand this. And so talk about your insights into how we might be communicating about vaccines and about COVID in a different way.
Yeah, thanks, Ignatius. You know, been thinking a lot about vaccine communication, vaccine hesitancy, since, you know, before we were developing the vaccines for COVID, and as we've started to roll it out. And I can tell you, at the health center that I work at here, it's been a lot of grunt work, you know, going door to door, meeting people where they're at, trying to understand their questions and concerns. And one of my colleagues and I wrote this article, sort of rethinking a little bit how to explain vaccine hesitancy and how to instill vaccine confidence. And it's an idea called lay epidemiology, which essentially means that normal people, every single one of us, has a sense of epidemiology, risks and behaviors and potential consequences that we have in our own head about the world around us. That's really informed by the people that we live with, the experiences we've had ourselves, the experiences we've heard from other people, and what we've gathered from the news media. And based off of all of that, we have a sense of the world and how we interact with it, and our sense of risks and benefits of things. And this is especially true with the COVID vaccine. Every person has heard something about it from someone else, from a friend, from a colleague who's gotten it, who's had a good reaction, who's had a bad reaction. They've heard about it in the news media. And with all this information, people create their own sense of what they think is right or wrong. I think, as Dr. Samoa said a little bit earlier, you know, we have a bit of arrogance in medicine and public health to say, like, this is the data, this is the right thing to do, therefore you should do it. And, oh, you're not doing it, let me just hit you in the face with more information about how important this is to do it. But that assumes a few things. It assumes that, you know, the people who we're trying to talk to don't understand that the vaccine is beneficial, which I think they do. I think the data is pretty clear, but people have other reasons to not get it. Some of which are founded in the evidence. You know, the FDA has, this is an emergency authorization. I'll be more comfortable getting it once it's fully authorized, which I've heard from a number of my primary care patients, to people just not wanting to take it because their friend had a bad reaction and they don't want to have it as well. And every single one of those reasons is valid and real to the person that's holding it. And I think the people, as Dr. Pannaraj said, the people who wanted to get vaccinated are vaccinated. You know, the people who've been pining for it have the vaccines in their body right now, and they've had them for months. The question is, how do we reach the people who are a bit hesitant about getting it? And it comes less down to having broad sets of information and data, and more thinking about who the person is, who the community is, and how do we convey this information in a way that's relatable and really digestible, not just giving numbers, but trying to personalize it, trying to personalize their stories, images, different ways that people could consume the information so that it aligns with sort of their worldview, and they're able to incorporate it into the decisions that they make. And, you know, even if we do a perfect job with that, there'll still be people who want to take the vaccine, and that's okay. But we want to do our best to try to make it as easy as possible to address people's concerns so they can make the best informed decision for themselves and their families.
So let me go back to Dr. Pannaraj, and then I'll come back to Dr. Samoa. So Dr. Pannaraj, you also talked about, you know, the classic case of a small business person who's running their own business, who may not even have access to healthcare, who may not be able to take time off to go to see a primary care provider, or even, you know, have time to go run to the local pharmacy now that the pharmacies are offering vaccines. So there are those other kinds of barriers that even folks that you don't see in practice. How do we, I think what Dr. Nuti is saying is, how do we reach out to get to those folks as opposed to the folks that are coming into the healthcare system?
Yeah, it's a great question. I mean, early on, there was a lot of issues with how do I sign up for the vaccine? You know, those internet signups were very difficult, especially during the time where when everybody was trying to sign up, and all the spots were full, and you'd have to enter your information 1,000 times before you could actually get a spot. Very hard for the elderly and for those who don't speak English or read and write English. They had different languages in Spanish, but not most of the other languages. So then, you know, as vaccine clinics expanded, we do now have almost all local pharmacies now give the vaccine, but they're still only during regular business hours. And so if you have your own business and you're working, it's hard to get there to get the vaccine. So the next step now, I mean, now especially as many of the vaccine clinics have seen a pretty big decline in the numbers coming in. So, you know, as opposed to the beginning where you were waiting in line for 2 hours to, even after you made an appointment, now you can walk in pretty much anywhere and get it. But I think the next step is now to kind of mobilize those personnel and you know, talk about like mobile vans, getting into community centers, places of worship, in schools. We are actually previously with influenza, we did several studies showing that if you have a school-based flu clinic, then you will vaccinate so much more of the patient population. And not only that, but many times the parents and the siblings as well. Asians tend to live in multi-generational families. So it's not just the immediate family, but it's, grandparents and sometimes an aunt, uncle, and their family. And so if you have those vaccinations clinics available in the community, even if it's just, once a week, once every couple of weeks, and people know about it, they will tend to come. If you have it in the schools, it's very easy. You have to go to the schools. If you have kids, you go to the schools every day. So it's really now about finding ways to reach out into the community rather than just be a sedentary place and have people come to you.
So Dr. Samoa, I want to come back to you and build off of these comments that, again, it's great to have providers like Dr. Nuti and Dr. Pannaraj who are thinking this way, but in the Pacific Islander community, you're one of the very few Samoan American physicians. There's, nurses, but, there aren't a whole lot of Samoan and Pacific Islander healthcare providers. And so we've got a handful of folks in public health departments, but a lot of folks just are working in the community or just are in the community and don't even identify themselves necessarily as even with a community-based organization. So there's capacity questions there, but I think through this, you've demonstrated that creativity, that initiative, that resilience of how you build that capacity that doesn't necessarily rely on, the traditional models of either healthcare or even community-based organizations. So talk about how this network really virtually got expanded and really very, very strong over this time.
So that part of my work, I don't know if there's any training for it, that you just kind of got thrown into the mix, and I was being asked to do things that are way outside of my wheelhouse. A lot of the attendees are former board members, so they know how much I hate public speaking, but I do it, and so a lot of this was sort of a steep learning curve, not just for us in regards to how to advocate, but how to work together, right? So there is a big divide between physicians and community-based organizations. And it takes a pandemic for us to really try to hammer out that relationship. And what it takes is knowing what your capacity is and how you can best advocate. So one of the things I'm very clear about when I'm asked to speak or when I'm asked to do something is whether or not I have the capacity to do that. If we're speaking about the community-based organization experience, I will refer those leaders to the table with the likes of HRSA and other sort of federal agencies, because I think what Dr. Nuti said was basically what we were stuck with from the beginning. One, we had no national voice. We were trying to sort of get people to sort of look at the high rates and disaggregate, and people just ignored us. And it wasn't until we started publishing, it wasn't until we started showing up in spaces with data, and so the AAPA, they did a survey which was across the nation, and we were about to get 1,200. We got 1,200 respondents, NHPI respondents, and we could have predicted the vaccine rates in April, because we showed that 46% of respondents were hesitant to get the vaccine. But when we look at it from a state-by-state level, it matched what is happening now in those states, where states that, and mind you, this is not a political talk, I'm not trying to draw a divide amongst us, But in states that voted for the Republican presidential candidate in 2020, the vaccination hesitancy rates are extremely high. So in Arkansas, they're about 70%. And mind you, this is about like 1,200 respondents across the nation. And in Utah, it was about 64%. We're seeing those numbers now. Yeah, we're seeing those vaccination rates now. And the reason why it's problematic is you're seeing rates go up, right? We're starting to see those rates plateau and start to creep up now, especially in those places that have high vaccine. And this is where we talk about the monolith, right? Because we're having difference in hesitancy based on ethnic group. In Utah, the primary demographic of the respondents there were Tongan, where we had high hesitancy, and we're seeing that. Whereas it's a little bit better among Samoans, in places where they're the majority of the population. Same thing with Hawaii. Their vaccine hesitancy changes depending on which ethnic group you look at. The reason why that's important is if you treat us like a monolith and you give us all the same money to do translational work, is that more, you're going to give it to people who don't need it, and you're going to take away resources from people who do need it. The other thing that we had to be very clear that Dr. Nuti mentioned before, and Dr. Pannaraj also mentioned a little bit, was the messaging, right? The people who listen to stats, the people who listen to expert opinion, they already got the vaccine. So what we've been having to lean on, and this is where our chronic disease experience comes in, is we have to draw on our cultural values. We have to call upon our health messaging that's based on where we come from, And so I think there was a campaign the word was to try to make it safe for us to gather again. But we were already gathering, right? We were spreading COVID in funerals and birthday events. And so we had to change our messaging. And our messaging is that if we belong to the same place, if our maternal home is the same place, then we have an obligation to each other to keep each other safe, right? And we use the history of us in the United States to help push that messaging. We came here with nothing but each other, and we built churches and we built communities, and we were developing like vaccine clinics to get around those obstacles that Dr. Pannaraj talked about, because we know the majority of our population were 42% were essential workers. And that's the group that's the most hesitant, and so we know we have to aim our services towards that. Because just like what Dr. Pannaraj said about the protective factors, in every state, we see protection if you have higher income and higher educational level attainment. But across the nation, we are poor and we have poor educational attainment. So we're starting at such a bad place that there is no protection when a public health crisis hits us, because you trade out COVID for diabetes, for cancer, for any other public health crisis, and we're still susceptible based on those social determinants of health. Sorry for the rant.
Thank you. No, thank you for sharing all that. So let me go back to Dr. Nuti, and Dr. Winston Wong, our chair, asked the question, have you seen or heard evidence of sort of the anti-vaccine? So not so much the hesitancy, but people who are affirmatively, either politically, religiously, whatever, opposed. There's clearly that. I'll come back to Dr. Pannaraj on this question as well, with some of the childhood vaccinations. So has that sort of issue of people just digging their heels in and saying they're opposed to it? You're on mute. Sorry.
No worries, no worries. I've had a number of patients say they don't want to take it. Interestingly, you ask why, and they don't want to say why. There's like, I don't want it. I'm not willing to be a part of the experiment. And like, can we talk about it? And they just don't want to talk about it. So I think there's definitely a subset of those type of people. Just as there is with any big thing that you ask society to do, there'll be a subset that just don't want to do it for whatever reasons that they may have. So it's definitely the case. I think I saw Dr. Wong comment, like, do we have this information within the AANHPI community? I haven't seen it. I don't know if Dr. Samoa or Dr. Pannaraj have. The thing I tend to follow, and I think I found a link to it here, is the Kaiser Family Foundation. They have a good set of, they have a good breakdown across the country, not really broken down by demographics of hesitancy and the reasons for doing it. And you'll see that, you know, there's this strata of people who have different reasons and different levels of not wanting to take it. You know, they're kind of on the fence, they're waiting for more information, they're worried about side effects, whatever it is. But again, I think people will find the reason to support whatever they want to do to begin with. And so I think we sort of just take it as it is and try to do our best to work with communities to create a culture where it's okay to take it and okay to sort of change your mind and take it.
So Dr. Pannaraj, anything from your prior research, particularly around sort of more of that ideological opposition from Asian American and Native Hawaiian and Pacific Islander communities?
Yeah. When we think about vaccine hesitancy, it does fall into different categories. So the anti-vaxxers are actually a pretty small number, but those are the ones that are ideologically against vaccines. And then there are those that are hesitant for other reasons, but you can talk to them. They're willing to talk about it. They might not change their mind, especially at the first time you bring it up, but they might, you know, down the road. At least they're open to thinking about it. Now, for anti-vaxxers amongst Asian Americans, to be honest, I don't think that it's that high, those that are ideologically against it. When talking about routine vaccinations, when talking about flu vaccine, that's why I think that there's a little bit more. And COVID vaccine, as I said earlier, will kind of fall in that line. So most of what I see right now is a lot of, you know, this question about, again, also just like Dr. Nuti said about how, you know, they don't really know exactly why, or they don't want to talk about exactly why. It has a lot to do with the vaccine being new. They feel like they're part of an experiment, even though over 300 million doses have been given just in the US alone. And so, but they still feel like, you know, we don't have enough information. And so then they're being studied. And so that there is that, but I do feel that there is some still room within the Asian community to talk about it and to get their once the community, you know, they know of other people that have received the vaccine that they respect and look up to, then it tends to then they tend to feel more comfortable. And so getting vaccination mobile vans out to some of those community settings where people can actually see their friend getting vaccinated, those kinds of things actually help a lot for just to bring a little bit of comfort to the feeling, because it's not that they're ideologically against vaccines, it's just this feeling of being uncomfortable, not wanting to be studied, you know, that they just that's where I think we can work with them. And then what Dr. Samoa said about, you know, making sure that they using that cultural aspect of, you know, if you're vaccinated, you're protecting your entire family. You know, you're protecting your grandma and grandpa, or mom and dad, who may get the vaccine but may not have the same protection as, you know, somebody who is a little bit younger, or for the, you know, when we have the vaccines for children right now, at least initially, it seemed with the initial strains of COVID, didn't seem like children were more major spreaders, but with the Delta strain, that seems like it's going to change, that children will become major spreaders, especially once school opens. So, you know, I think that communication has to be there, that, you know, you're really contributing to the protection for your entire family, especially those that are more vulnerable and need the protection.
Great. And so David has shared the very unscientific poll results of the participants. Again, disturbing to see that so many know somebody that is hesitating or choosing not to be vaccinated. The good news is that so many of the participants responding here are still keeping mask wearing in public. And I think that's, I do it in part just to set the example that it's still just the social norm that it's okay to be wearing a mask even though I'm vaccinated. So let me conclude, but do one final go around to each of you. We've already heard from Dr. Samoa and Dr. Pannaraj some really great sort of culturally tailored messaging about really appealing to that sense of community, keeping family and community safe. So let me just ask in the final minute, go around to each of you. Are there other messages that you've heard that you feel could be particularly effective with that cultural context of reaching our Asian American, Native Hawaiian, and Pacific Islander community? So anyone who wants to chime in.
I'll go. I think the Pacific Island communities have a very large faith-based connection. And so a lot of churches are able to motivate behaviors that physicians are not, right? And so, no one wants to talk to me about sort of like prostate exams, but they'll talk to each other, at the water cooler, at the bingo hall. And I think that's kind of, we need to do a better job integrating church into our public health messaging. The problem that we have now is we only go to them when we want them to talk about something. And I found that that's a really bad way to improve any type of outcome. And mind you, I'm guilty as much as any other physician, but trying to establish relationship with these community-based organizations based on mutual benefit, where their capacity increases, allows us to do more work, in places that we're commonly not effective in. And then, also we have to do a better job of like recruiting different groups that are more apt to get the word out. So, there is a section of Pacific Islanders who are tired of me because I've talked about diabetes for 20 years. And so when it comes to the vaccine, it's just it's just white noise, right? But they'll listen to my parents, they'll listen to, my sister when they're at work, and I think that's where we kind of have to get out of this medical centric model of engaging, improving health outcomes, because it's not working for, at least for our community. I think that's what's pushing us to try to do things in a different way, because our numbers, they're still the highest in these states. I think we're out of the 20 to 21 states that report disaggregated NHPI data, 16 out of those NHPIs have the highest confirmed case rates. And out of the 19 that collect mortality data, 11 out of the 19 report the highest mortality rates. So, this COVID is just sort of the only time we've been able to sort of broadcast the health disparity to an audience that is actually willing to listen to it. And so the iron is hot right now for us to do so.
So we are at time, and I want to thank all our terrific panelists for sharing. I think on that final note of really thinking about the assets that communities bring, including faith-based organizations, the diversity of the different types of churches and temples and other faith organizations, depending on that particular ethnicity and culture, and really needing to understand and build those relationships, as Dr. Samoa said, and not just go to them when we need them, but really build those relationships. So thanks to all our panelists, thanks to all our participants for listening in, and look forward to our next in this series of conversations. Thanks, everybody.
Thank you.
Thanks.